Hello, everybody, and welcome to the latest webinar in NCSA's webinar series. I'm Jill Escher. I'm the president of NCSA. I'm very happy to be hosting today. And our guest today is Dr. Arthur Westover. He is an associate professor of psychiatry at UT, which means University of Texas, for those who don't know, Southwestern Medical Center, which is in Dallas. He earned his medical degree at Baylor College of Medicine, also in Texas. He completed his residency in psychiatry and master's degree in clinical sciences at UT Southwestern. He is director of adult autism services at UT Southwestern. He's also assistant director of the outpatient psychiatric clinic there. He also has a history doing research. He's not just a clinician. Importantly, he serves on our board of directors at National Council on Severe Autism. Thank you, Dr. Westover. And he also, as you will learn, has a teenage son who is on the spectrum. Quick note that, of course, I have to say this, nothing in here constitutes medical advice. Hopefully this will provide you helpful information, but none of this is meant to direct you regarding the care of your child. With that, Dr. Westover, I would like to turn it over to you.
Thank you so much, Jill. It's a real pleasure to be here this evening and with all of you on this webinar. I consider it a real honor, and I hope that I'll be able to share some information that's useful for you. I know all of you are coming from different situations, different backgrounds, and I hope there's something in here that will make your time worthwhile in this conversation today. Let's see if I can advance the slides. Just very briefly, I don't have any financial conflicts, and we can proceed on with a little bit about what we're going to focus on in this discussion. So these first 3 bullet points, I'm going to try to go through very quickly, but Jill has let me know that you guys are really interested in treatments and focusing on treatments, and that's such a broad topic that we can't really, discuss all the various permutations. That's where finding the right psychiatrist and someone who really understands the science and art of psychiatry is so vital. We're going to talk about how to find that person. What is the role of a psychiatrist? How can I have a good experience with a psychiatrist? How can I find a psychiatrist and make that psychiatrist be effective in his or her role? A better understanding of psychiatric treatments and how a psychiatrist might help with severe behaviors. Just want to briefly touch a little bit more on the story of how I got to this situation. So I think this is pertinent, not so much to talk about myself, but to talk about how I was quote unquote created, how I came to be here in this moment with you guys, and how that same thing can happen in other places where you are, for example. So I finished my residency in psychiatry in 2006. This is just with adults, no, just a little bit of training with kids, but I'm not a child and adolescent psychiatrist. I'm an adult general psychiatrist. I did a lot of work in clinical work in the psychiatric ER, in the county hospital inpatient unit, and also doing research. I think a key part of this experience was I was very accustomed to working with very ill, decompensated persons with very serious mental illness, including aggression and things like that. I was also very used to working with people that didn't want treatment, that were there involuntarily. So coming from a background where I was kind of ready to, I at least at that time, I thought like, oh, I've seen very sick persons, and I think that helped prepare me for all my outpatient experiences later. In about 2015, the psychiatrist at UT Southwestern that was seeing folks with Fragile X left UT Southwestern, and I was asked to take over that care. So that was my first kind of introduction in this world. A pretty substantial population of persons with Fragile X also are on the spectrum. And so I started working in that population. Then in 2016, I started working full-time as an outpatient doctor. And our chair, Dr. Taminga, asked me if I would start to see persons on the spectrum. Would you start to see adults who have autism? And I might, use the phrase autistic adults or adults with autism. I don't mean any offense in any way, but I might go back and forth with that terminology. I was at first a little bit hesitant because I said I didn't have any training, I didn't have any experience. And while having a son on the spectrum might motivate me to go forward with that, it might also hold me back. It reminds me of the phrase, the cobbler's children have no shoes. I was a little bit afraid that I might not have the energy and wherewithal to do work with persons, autistic persons, and also take care of my son. But I think overall that experience motivated me to go forward, and I'm glad that I did. The small amount of hesitation I had at the beginning, my fears that I had, I was able to overcome them and actually saw the other side of this. And part of my message today is going to be this is very rewarding work, and we need not only experts in it, but we just need every psychiatrist to be able to do this work, and it's work that every psychiatrist can do. Becoming an expert is in some ways putting the sign on, in front of your office and gaining experience over time. I come to you with some humility in that, I'm not an expert. I'm just a fellow traveler who's gone down this road and tried to learn along the way. I want to thank my patients, their families. Some of them I think are on the webinar now for sharing their experiences and helping me learn as I've gone through this journey here. Just briefly about being the director of adult autism services at UT Southwestern. We don't really have time to talk about all the services we offer, but we have a transitional age youth clinic. We have a nurse practitioner that works with me. I have a resident PGY4 that is specifically rotating with me, seeing autistic folks and learning along the way. I have 2 other residents that will be coming with me this year. So we're trying to build up the amount of services that we can offer, and specifically the training we offer for the upcoming generation of psychiatrists and providers. We won't focus too much on this slide, but a psychiatrist is a doctor who's been to medical school and is trained to help people with mental illness. A psychiatrist who treats adults as a general adult psychiatrist has gone through 4 years of training, and a child and adolescent psychiatrist has been through 5 or 6 years of training. An advanced practice provider has less training, but has learned on the job. So ideally, a person that is in that position will be working under a doctor and will be learning as they go, and of course can become very good at their work with time. Why would you want to see a psychiatrist? Well, one, maybe you're pursuing a diagnosis. There are some people that come to me, not often, but sometimes, that haven't yet received the diagnosis of autism that actually are autistic. So for example, someone with a genetic disorder, but hasn't yet received a comorbid diagnosis of autism. Again, I mean no offense by the word comorbid, it's just a medical term that we use for conditions that go together. You may need to be diagnosed related to other conditions such as OCD, anxiety, depression, ADHD, and other common conditions. And we'll talk a little bit more about that. Of course, treatment is the #1 thing we think of in psychiatric medications. Psychiatrists are trained and expert in psychiatric medications, as well as psychiatric intervention. So this is more of the cutting edge of psychiatry, using Spravato, for example, which is esketamine, nasally inhaled version of ketamine. TMS stands for transmagnetic stimulation, ECT, electroconvulsive therapy. We'll talk a little bit more about those things later. A psychiatrist can help with coordination of care, can work with the therapist, the behavior therapist that you're working with, the insight-oriented cognitive behavioral therapist you're working with, and can also coordinate with specialists. So for example, work with the neurologist if your child has seizures. Can work with primary care doctors. At UT Southwestern, we're working to provide and create specialized primary care for autistic adults. And also, there's some element of just being a social worker. Every psychiatrist, to some extent, is a social worker. And I found in this area of psychiatry that I myself am learning the social work aspect, learning what resources are available, learning from the families, sharing ideas. The need for psychiatry is high among autistic adults and children for that matter. This is a study from Sweden. And the takeaway from this study is that the great majority of autistic individuals have at least one psychiatric diagnosis, and the risk of psychiatric hospitalization is much higher among autistic persons than non-autistic persons. So, for example, 5 times the hazard ratio risk of having a psychiatric hospitalization. This next slide is also to illustrate that the other kinds of common psychiatric diagnoses that we treat in psychiatry are very common among autistic persons and autistic adults, specifically with this slide. So for example, OCD, they're kind of near the bottom of this graphic, almost a 15 times odds ratio or risk of having OCD compared to folks without autism spectrum disorder and so forth. You can see these other disorders listed here: depression, anxiety, psychosis that may be associated with schizophrenia and so forth. So I'm just kind of trying to build the case that psychiatrists are really needed for autistic adults. And we don't have as many as we should that actually do this and specialize in this and feel comfortable doing this. I'm sure a lot of you already know this slide, which is that what is available for children on the spectrum is very different than what is available for adults. This is just, what I've listed here is mainly medical care, but this also goes towards therapy. I remember 7 years ago, it was a little bit more difficult to argue that ABA would be appropriate for an 18-year-old, a 20-year-old, a 25-year-old, and so forth. It's kind of interesting that in the non-autistic world, we do therapy for all kinds of adults throughout the lifespan. And it's kind of weird to imagine that at some point we thought that perhaps therapy was not required for adults. It certainly is required for adults. In terms of the adult medical provider situation, you go from the situation of having providers, and then what do you do when they become adults? Well, for a time, you might stay with your pediatric provider, but eventually they may be telling you, you've aged out. Where are you going to go? What are you going to do? Who are these other professionals that are going to help? Why aren't there more psychiatrists who take care of autistic adults? It's mainly a lack of training and a lack of experience. I would also argue there's a lack of prioritization in academic medicine. It's just not been a focus historically. There are some reimbursement issues. Most psychiatrists that are in private practice, at least here in Texas, I think in most of the United States, do not even take private insurance, much less Medicaid and Medicare. They only accept cash. And so, you're in the situation of perhaps being on Medicaid, and you're having a hard time finding a psychiatrist who accepts Medicaid, much less a person that is comfortable working with autistic adults. I think there's some negative bias as well that this might not be an area that many psychiatrists think is rewarding. And again, I'm going to argue that that is patently false. It is quite rewarding and very rewarding. And I think this is an area that psychiatry needs to expand and go into. Now, I know you guys are interested in treatment, but I've got a point to this related to getting better psychiatric care for you guys. How do you find a psychiatrist? Again, I won't go, talk about this too much, but referrals from other people, hearing what other people are doing, other parents, autism organizations. You might call your medical school that's closest to you and say, do you have anyone that sees autistic adults, perhaps even with severe autism and severe behaviors? The answer might be yes, the answer might be no. I would say if the answer is no, you could say, I want to see someone anyway. Can you please just put me in? You can advocate with the medical school for them to have someone that does this, even if they don't have someone who does this. I know that transition of care from the pediatric world into the adult world of services in autism is a major concern, and there are many people talking about it, and we have a lot of work to do in academic medicine, especially to make this happen. It's something that we're working on here at UT Southwestern. Our folks that are at the Autism Center here at UT Southwestern at Children's, moving them into adult care, adult psychiatric care. Just briefly, I mentioned the lack of training experience, the idea that it won't be rewarding, that there is going to be isolation and lack of support, that you won't have social workers, there's no therapists that are working directly with you, it'll just be you, and you won't know what to do. The fear of powerlessness. I can say as a doctor, the thing we fear the most is not being able to help and failing at our job, for people to come to us for assistance and us feeling like we have failed in being able to provide assistance. However, after
Dr.
years of work
Westover,
and experience,
I'm gonna barge in for a second.
Sure.
Somebody says that he doesn't see the slides, and people, maybe you can tell me in chat or in Q&A if you are seeing slides. Are you seeing slides? Let's see, what do
Let's
people
see,
say?
it says you are
Yeah, I can
screen
see
sharing.
them. Okay. Well, I'm sorry, friend. You're the only one who's not seeing them. I will bow
Okay, very
out
good.
and Please go ahead, Dr. Westover.
Sure. Although I kind of miss the old world of no slides where guys would just go up to the blackboard and start talking. I guess I'm that old. So, but anyway, the reality of this work is that you gain experience. You have the tools. I'm speaking to psychiatrists. They can do it. It is extremely rewarding. It's so easy to really, feel motivated to help these patients. Easy to root for. Parents are great. People are so grateful for help. Parents are wonderful. It is difficult in a way that is challenging, but also rewarding. And definitely in my work, I've not been alone. The families involved, the patient's involvement, therapists' involvement, and I'll have another slide talking about that. And the fear of powerlessness. Well, we can help, and we can help even in very severe cases. And it's our duty to help, and we must help. We shouldn't be walking away. So you might be sitting there saying, I can't find a good psychiatrist. I don't think my psychiatrist is doing a good job. My psychiatrist doesn't understand autism. I would say this: train your psychiatrist. So I'm here today because my patients trained me. The families trained me. The patients came to me with ideas. The parents came to me with ideas. I studied on my own. You can train your psychiatrist. You need to get your foot in the door. You need to find the right person who's open, who's willing to learn, who's willing to collaborate, and you can train your psychiatrist. Planning for your first visit, again, don't want to go over this. We have limited time, so I'm going to go through this quickly. You probably have 60 minutes. What is the problem? Why are you here? Is there a diagnosis of autism? Is there a formal diagnosis? Has there been testing? What are the other conditions that may be in play, like depression, anxiety, behavior, self-injurious behavior? What about non-psychiatric conditions that may be in play as well, that may be contributing? For example, I've had a patient where I was told the dental work was all fine, and come to know it wasn't fine. And it was actually quite severe when they went into the dentist to get checked. And perhaps some of the agitation was related to being in severe pain. Another patient who medications were not effective. I expected a particular medication to be quite effective. It wasn't. I was puzzled. The primary care doctor, or actually it was the hospitalist, did a CAT scan, an abdominal CAT scan, and found that the patient had kidney stones. So that explained why the medication was not working and the patient was agitated. It was severe pain from kidney stones. Of course, when that was resolved, the situation was quite different. And we'll talk a little bit more about this. I'm going to go through what I considered I have a slide that shows what I consider kind of my way of thinking and algorithm. But what treatments have been tried? You can't come to your psychiatrist with 100 pages of information. They don't have the time to read that. You need to summarize it if you can. If you have a list of, for example, all the medications that have been tried that you're aware of, the dates that they were tried, what the results were, did this work, how did it work, were there side effects, that is super useful and super important. Of course, if you don't have that, that's okay. Has behavioral therapists been attempted? What is the level of function? What's going on? Like, what's going on a day-to-day basis? If you're prepared to answer these questions, that'll be super helpful. Let's briefly touch on the use of psychiatric medications. I know that you guys, many of you, have experience with these medications, both for good and bad. I've listed off the major categories. These aren't all of the categories of psychiatric medications, but the main ones: antidepressants, antipsychotics, mood stabilizers, ADHD medications, benzodiazepines, sleep medications. It is beyond the scope of this talk to go through each of the medications and discuss the scenarios where we use the medications. I'll touch on a little bit more later, but suffice it to say, if we understand what's been used before and what happened, it will give us information about what's going to be useful in the future. So for example, every time we tried an SSRI antidepressant, there was agitation. That's telling me increases in serotonin are probably not going to be helpful. Or we tried 3 different antipsychotics for agitation, and there was just incredible weight gain on all 3 of them. That's useful information. Or we tried an antipsychotic and things got worse. I can go through each of these medications and provide you different scenarios with how they worked, where they didn't work, what the side effects were. That's really where you have to find an expert psychiatrist that has this experience using all of these medications in different venues. So that's one thing that's been useful about my experience. I didn't start working with autistic folks from the beginning. I worked in all areas of psychiatry using all kinds of medication. So the breadth of knowledge I have about these medications is not specific to autism, but is specific to psychiatric conditions in general. If you provide better data, you will get better decision making. It's really hard for me if a family comes to me and I can't make heads or tails out of what's working, when it's working, how it's working. And when I get better data, it is better. What is the target? What's trying to be improved? For example, ABA therapists tracking information and being able to provide me very specific data about changes that have happened over time. We sometimes know that a person's gut feeling is not always correct. That's why we use scales in psychiatry. Patient, may come to me and say, my depression's not better, but we look at the depression scale that they filled out and it's remarkably better. And I'm able to talk to them and say, maybe your depression is better. Let's look at this. Let's examine this. The same thing applies with autism. There's an art to this, and a science. And a good psychiatrist knows both the science and the art. Where the art comes into play is where we lack the science. In other words, using best guesses of medications. For example, just because a couple of antipsychotics are approved in autism doesn't mean that you would never use a different antipsychotic. That's getting into the art of medicine and that judgment. And that's a collaborative process. All of this is a collaborative process. A good psychiatrist is collaborating, not dictating. I mentioned here a parent's medication guide. If you Google that, autism spectrum disorder, that last line on this slide, there's a very good guide that gives specific instructions and guidelines and help in what a parent should think about related to medication for autism. So highly recommend taking a look at that. Again, it's not going to tell you what medication is best or effective because that answer is highly specific to each individual person. A couple common medication scenarios that I've seen, risperidone. So risperidone is approved for irritability and autism. For better or worse, it gets used a lot, especially in the pediatric population. I think part of the reason is you have a lot of non-psychiatrists that are prescribing the medication, like a pediatrician or a developmental pediatrician or neurologist. They just don't have the experience with, for example, other antipsychotics. Risperidone has a lot of problems associated with it. Weight gain is one, and of course, other antipsychotics can cause weight gain as well. But the increased prolactin level that can be seen, which can cause all kinds of problems, that's somewhat specific to risperidone. And this is kind of a common scenario that I've run into. Risperidone, we tried to get off of it, we can't. It's not working, but it's causing tremendous problems. Good psychiatrist can help you work through that problem, that scenario. Antipsychotics causing weight gain in general is a big issue. We can talk whether antipsychotics are overused or underused. That's another discussion for another day. But when you're in the situation with weight gain and it's helping the medication, we need to figure out a way to limit the weight gain and stop the weight gain. And luckily, we have better options than we've ever had before. I listed off a few sorts of strategies that are pretty common towards helping in that situation. And sometimes that's in collaboration with other providers. For example, GLP-1 medications that you've probably seen in the news, lots of people are losing a lot of weight with that medication. Collaboration between psychiatrists and therapists. So this is something pretty unique to my work in autism, which is to have a therapist actually come with the family and the patient to the visit. Super helpful, super useful. When we're doing video visits, because those are increasingly common in psychiatric treatment, having those therapists actually there on the video, whether it's in the home or separately from another feed, super helpful. So the dirty secret in psychiatry is that where a patient is seeing both a psychiatrist and a therapist, it's really difficult for us to collaborate. Now, at UT Southwestern, if the therapist is working at UT Southwestern and they're working right next door to me, and we're all in the same computer system, yeah, it's a lot easier. But outside therapists, outside systems, it is really difficult. And I've actually found that this world of treatment in autism is much more collaborative in terms of therapist input. And that's a real bonus and something we should really promote and do more often. All right, so getting to tough cases and what we should do about them. What about the toughest cases? Self-injurious behavior is very common, 42% in one study, and persistent. It just sometimes doesn't go away, and it's highly detrimental. This can include self-injurious behavior as far as aggression and agitation, can lead to aggression towards others, and, for example, vocalizations. If you've been around someone who is constantly screaming during all waking hours, it sure can cause a lot of difficulty and prevent someone from being able to go out into the world, go to stores, go places, and go to restaurants and do things. It can be very difficult. The sequelae, limited social services and staffing, not being able to get into programming, being excluded, not having the same housing options as other people, having very serious injuries. This is a major one, exclusion from psychiatric hospitalizations. In what other kind of mental disorder, by that I mean a DSM diagnosed mental disorder, do we say your child is too ill to be hospitalized? You know, it hurts me as a psychiatrist that as a field, any of us have ever said that, and many of us have said that, and it is the most common scenario. We need to create a medical world where these patients are not excluded from psychiatric hospitalization. And where we don't have the correct facilities and staff to do that, we need to create it. But this is a problem that we face. Parental guardian burnout and isolation is another major problem. Of course, as I mentioned earlier, we need to think about medical considerations. Epilepsy could be another reason for aggression and agitation. Catatonia is another thing. We'll talk more about catatonia in just a second. And there may be specific genetic syndromes that are more likely to have aggression and self-injury. That's where genetic testing can be useful and can be useful in other ways as well. Pharmacological approach to self-injurious behavior. There are a couple of antipsychotics that are approved in this area, risperidone, which I've already touched on, and aripiprazole, which is Abilify. We really need more clinical research in this area. Autism Speaks is working on helping organizations, nonprofits, academic centers do better in this regard. And this also gets to where it is the art of medicine versus the science of medicine, where science has failed us, where we're lacking studies. That really relies on the psychiatrist and the team and the system for coming up with solutions. So I have this little note to myself here, National Council on Severe Autism Facebook thread. I think it was about a year and a half ago on the Facebook page for the National Council of Severe Autism, on severe autism. And someone had posted, if you are willing to share your experience with what kinds of medication strategies have worked in the case of severe behaviors, families just want to share ideas, please share those ideas. So I was very curious and very interested in that particular thread because this is right up my alley. This is what I do every day. And I went through all of the answers in that thread. And to me, it was like a random list of psychiatric medications. In other words, there was no rhyme or reason. Every situation was different. I saw people report that antidepressants worked. I saw people report mood stabilizers worked, antipsychotics worked. You know, just everything you can imagine was like in that thread. It just tells you there is no magic formula where there is just one answer. There is no separate toolbox that I have that other psychiatrists don't have in terms of medications. It is the correct application of these tools, which are not perfect. They don't always work. This just goes to the complexity of the problem. And we'll talk a little bit more about how I think about this problem in a future slide here in just a second, which is this slide. So this might be my most important slide, at least I think it is. And this is the way that I think about these cases of severe behavior. I actually came up with most of these responses when I replied to someone or replied to a thread on the NCSA Facebook page. So I've added a couple things since then to this list. But number one, are there physical medical problems that may explain the agitation? So I gave a couple examples, dental problems, kidney stones. There could be many other examples, headaches, migraines, just anything you can imagine that would cause a person to not feel good. Is that happening? GI issues, constipation, and so forth. We have to consider all of those things. Number two, have these things been addressed by a therapist? So, for example, has there been an ABA therapist involved in a patient that may have severe behaviors that is minimally verbal? Have we understood if there's a behavioral basis for what's going on here? I don't get what I want, therefore I have learned to become aggressive, and that's how I get what I want. A behavioral therapist will help us better understand that situation and implement things that can help that person get what they need, get what they want, but do so in a way that is not so difficult and doesn't cause so much harm. Are other psychiatric conditions present? So, for example, is there a mood disorder? Is there depression? Is there OCD? Are there panic attacks? Are there signs of psychosis? This may help guide sort of a medication strategy or intervention strategy in trying to understand what we want to think about. This is how a psychiatrist thinks. We think in terms of algorithms. We have like a depression algorithm. We have a bipolar algorithm. We have an OCD algorithm. We have an algorithm for every single psychiatric condition. What algorithm best applies in your situation, if any algorithm applies at all? Of course, we don't have time to talk about all the treatment choices in every algorithm, but that's where your psychiatrist earns their keep, is in understanding the algorithms and how to apply each of those algorithms. Number four, have catatonic symptoms been present as part of the clinical picture? I'm going to talk about catatonic symptoms in just a minute in some future slides. Catatonia is the thing that if you're not looking for it, you never see it. If you are looking for it, you can see it quite often. And this is something that is sometimes missed, and I'll talk more about this. Prior medications, how have they been used? What were their effects? Sometimes we can see a pattern. If we see a pattern of certain kinds of things working, that may tell us what might be the best in the future. So, for example, serotonin up, has that been good? If we increase serotonin, if we increase norepinephrine, is that good? If we block dopamine, is that good? If we increase dopamine, is that good? Think glutamate changes. If we think about all the different kinds of things these medications do, how did they work? What does that tell us? Most of the people that come to me as adults have been on medications, not always, but most of them have. And there's usually something to be gleaned or some understanding that can be had. I'll give you a quick example. Patient with agitation for years and years and years, all kinds of medications, comes to me. I'm getting a medication history, and I ask about benzodiazepines, and the patient has been on Klonopin. Wouldn't be surprised if the mom's on the webinar right now. Shout out if you're here. But she mentioned to me that he'd been on Klonopin and the dose had been like 5 milligrams at one point. And I thought, that's awfully high. I said, why was the patient on such a high dose? Well, it worked. It was kind of like one of the only things that really worked with this agitation and self-injury and vocalizations. And when I say vocalizations, I mean like yelling and screaming all the time. I don't just mean talking. And I thought that's interesting. And I said, well, why did you reduce it? Well, the next doctor who came on board said that's way too high a dose for anybody. We should reduce that medication. And that was a hint to me that a particular strategy might be effective. In that case, thinking about catatonia, because benzodiazepines are the first line treatment for catatonia, for excited catatonia. Just to give you an example of looking at patterns of response. In terms of number 7, the least side effects are best chance of working. So I found, for example, if a person comes in agitated, it might be that they could respond to a very simple and safe medication. For example, Zoloft, sertraline, an antidepressant. However, a person might come in and be seen by a medical professional. They have some agitation, and the first knee-jerk reaction might be to put them on antipsychotic medication, which, on paper might work better. However, there is the chance that there's a lot more side effects with that medication. So sometimes you might say, I'm patient, I can work through this algorithm using safest, least side effects strategies, versus I really need something to work now, and I'm willing to work with medications that might work better and faster, but have more side effects. That's something that has to be thought about. We need to think about whether what we've done has been adequate, and can we judge whether it's been adequate. For example, saying that a medication didn't work after 1 week might not be an adequate amount of time. Of course, sometimes we have to stop a medication after a week because of side effects, but have we judged this adequately? Are we changing things one at a time if we can? Because then we can make better inferences. If we're making 2, 3, 4 changes, sometimes we're not going to be able to interpret what's going on. Now, that is a luxury. Sometimes we don't have that luxury. But where we can, where we do have that luxury, it is much better to make one change at a time and try to judge what that change accomplished. Is there an unknown genetic disorder? So perhaps, some of you on this call have adults. So I'm speaking to parents. I realize that I have patients here as well, but speaking to adults, you may have done genetic testing 10, 15, 20, 30 years ago. Maybe not 30 years ago, but many years ago. That genetic testing is now inadequate. It will not answer the question. Our genetic testing is much better now, and it can be helpful, and I'll discuss this a little bit later as well. This last one, number 11, is there a neuroimmune disorder? I'm going to be discussing that. So in my future slides right here, I'm going to focus on number 4, catatonic symptoms, a little bit on number 10, and a little bit on number 11, genetic disorders and neuroimmune disorders. So here's a little bit about catatonia. So Dr. Grossman, a local psychologist here in Dallas, who has referred patients. We've collaborated together. When I was first working with him, he said, "Have you heard about catatonia and autism?" And I said, "No, I haven't. I'm kind of familiar with catatonia, but I've never heard of that concept." He said, "Here's a paper, read it." And so I read it, and I thought, that's interesting. So catatonia occurs in autism, not just schizophrenia. Most psychiatrists think of catatonia as only occurring in schizophrenia. That's the bias in the field. And I read this paper, and it planted the seed in my mind that I might run into someone who has catatonic symptoms in the future. I'd recommend reading this article in The Atlantic from a few years ago, 2016, and Amy's book, here, Each Day I Like It Better, is a great book. And Amy, whom we referred to in the introduction, who just has a op-ed in the Washington Post that came out today, I believe, has written this great book about her experience with her son. Speaking of sons, in that original, near the beginning of my presentation, the little boy on the train window, that is my son at a younger age. And but anyway, he's been a big inspiration for this. And so I'm thinking about Amy's son, describing her son, thinking about my son as well. I forgot to mention that earlier. But this is a great book where Amy discusses a lot of really interesting, great things about the science behind this. So we're going to discuss this a little bit. Catatonia and autism is common. Up to 10% of autistic persons may experience catatonia. There are a couple of different kinds of catatonia. One is retarded catatonia, which means slowed, psychomotor slowed down in movement, mutism, inhibited movement, posturing. So for example, I have a patient, probably level 2 autism, who can converse with me, but he experiences these episodes of posturing, of stiffening up, of just holding a pose for 30 minutes. Can't explain to me why he does it. He's just like, I'm doing it. I don't know why I'm doing it. We determined in his case it was likely retarded catatonia. We gave him lorazepam. He has responded excellently to lorazepam, and this posturing has gone away. Had a patient who stopped walking, laying on the floor, on the ground. I said, let's try lorazepam. The patient started walking back to their original status. It can be pretty amazing when you discover catatonia and treat it, that actually really, really cool things can happen. So excited catatonia is the opposite. It's excessive motor activity, restlessness. Stereotypy refers to repeated movements that are atypical. Impulsivity, frenzy, agitation, combativeness. So being able to recognize catatonia is really important. My next slide will talk more about recognizing catatonia. The first-line treatment for catatonia is not antidepressants, not antipsychotics, it's benzodiazepines, the same sorts of things we use for generalized anxiety, panic attacks. Benzodiazepines, so like Xanax, Klonopin, Valium, and Ativan, which is lorazepam. Lorazepam is usually used first because it's the cleanest, it's the safest one to use in the hospital, for example, and so we usually use that medication. This is some data from Dr. Wachtel, who's been a mentor of mine. She's also on the board of NCSA, and I've learned a lot from her, but this is from her study where she talks about what she's observed in terms of response to lorazepam, which is Ativan. in the cases of catatonia. Now, the definitive treatment where benzodiazepines don't work is electroconvulsive therapy, which is ECT. We're going to talk a little bit more about that in a second. Let's talk a little bit more about catatonia. I think this article by Dr. Ghazuddin, I hope I'm pronouncing that right, at the University of Michigan has been useful in terms of discussing the subtleties of catatonia. So some psychiatrists feel like if you don't have catatonia, the moment you are presenting in front of the psychiatrist in their office or on video, then you don't have catatonia. Or it has to be the most classic case of catatonia, or it's not catatonia. I have more nuanced views of what catatonia is that fit more with what this article talks about. I put the full reference here on this slide. It may require a subscription to actually access, but our university has access to that. And anyway, if you can get a copy of this article and you want to know more about catatonia, this has a very good description of it, and I've summarized it in these cases in this slide. Motor, 3 domains: motor, speech, and behavior. Can be new onset or considerable worsening of pre-existing symptoms. On the motor side, change in overall activity level, changes in movements, posturing, staring. I've had a patient, for example, that doesn't cross thresholds, gets stuck, won't move. Changes in muscle tone. So this is the classic one that psychiatrists often think of when they think of schizophrenia, which is waxy flexibility, which is the patient that holds a particular posture, kind of like an action figure, and doesn't move. Gait changes, stupor, self-injurious behavior. So this has been a change in how we think about catatonia, that sometimes self-injurious behavior is actually a form of catatonia. And so that provides a whole different kind of aspect of treatment that we can look at. For example, benzodiazepines. Chorea, sudden and unintended jerky movements. I'm now working with a patient who had terrible chorea, who couldn't even sit in a chair in my office, who was laying on the floor, moving his arms, his neck, unable to do anything. We were able to treat and help him, and his chorea movements have largely gone away, which I think is because he was experiencing catatonia. Changes in speech and changes in behavior. So a regression or decline in skills, repetitive OCD-like behaviors. So for example, sometimes what appears to be OCD at first can actually be catatonia. Bizarre behaviors, psychosis-like behaviors. And it can be that antidepressants and antipsychotics don't help, and sometimes they can actually hurt. So you might actually have a situation where person's been diagnosed with schizophrenia, but because they appear to have some psychosis, but it's actually catatonia. So having catatonia on the mind, at least considering the idea, is going to be important for any psychiatrist. I always see that I'm already talking too much and going over time, so we'll try to go through things a little faster here. But I think this is really important because out of the, all the people on this, there's probably at least one person here that's saying, oh my goodness, I think my child may have catatonia and it's not been discovered. So if you learn more about catatonia, you might find a new paradigm that's not been treated and could be treated. Imagine if low dose, medium dose, high dose benzodiazepine led to incredible functional benefit. That would be amazing. Just really quickly, this was the first case. So remember, my colleague had told me about catatonia. I thought about it. I read the paper, and it wasn't, but like 3 months later, that patient walked in, and I thought, oh my goodness, I think he has catatonia. And he was literally destroying my office. His father was wrestling him in my office. He was wearing a harness, and the father was holding the father. The father was like a big guy too. He looked like he could be a linebacker, and it was just a mess in my office. And I thought this could be catatonia. I've been on a number of medications. He had this dramatic appearance. He was having these frenzied episodes. To make a long story short, we tried benzodiazepines. We tried a number of other medications with not really definitive benefit. But just for sake of time, I'll skip over this. We eventually started electroconvulsive therapy. Now, some of you are not familiar with electroconvulsive therapy. It's beyond the scope of this discussion to talk about the full history of it, how it's used, but it is used for depression mainly, but for other causes as well. It is the definitive treatment for catatonia. And it is a humane, safe way to treat things. It's not without some side effects. But this was the first time our team at UT Southwestern had ever considered doing ECT in the case of catatonia for autism. And this was our experience with the very first patient who underwent this. And it was dramatically effective for this family that had been suffering for a very long time. And this patient who had been suffering, this brought him back to his best self, to his best level of function. By October, after 15 treatments, he was back in school, the student of the month. He was continued in long-term ECT treatment, meaning that when this is effective, it is not a cure. It is something that is a treatment, not a cure, and he continues with maintenance ECT. Now, in his case, recently, things have gotten a little bit worse, but our ECT team is responding by doing a brief trial of a little bit more ECT in terms of frequency, and I'm sure he'll soon be back on track. The parents said this saved our lives. Now, we have other examples of this that I don't have time to go into, but we know from the literature, because we're going to go over that really quickly, that this can be a very effective treatment for these cases where many other doctors have given up and said there's nothing we can do, nothing can work. Undiagnosed catatonia can be dramatically improved and treated with electroconvulsive therapy. Dr. Wachtel has been a real leader in this area. This is data from her study. Data from Dr. Joshua Smith at Vanderbilt recently came out in 2022. Again, dramatically effective for patients. And we're growing in our experience at UT Southwestern. I want to say over 10 patients since 2018 have received ECT. We've not published a study on this, but we're gathering and learning in our own experience in this area. Let's talk a little bit about psychiatric hospitalization for autistic adults. It's almost non-existent. Why? It's because historically we haven't done it. We lack training. There's a bias against it. Could be expensive. There's a concern about what if we get patients, but we can't discharge them because they don't have any place to go. There is a hospital that serves this population at the University of Pittsburgh for adults. Again, we're speaking about adults here. Dr. Wachtel at Kennedy Krieger as a hospital for children and adolescents. At UT Southwestern, we're building a new state hospital, which will be very large, and I'm hoping that we will have services for autistic adults and kids at the hospital. A lot of people end up in emergency rooms, and a lot of people end up, for example, in a medical bed where, for example, if they come to our hospital at UT Southwestern, we'll actually have a psychiatrist be able to round and coordinate with the team, see the patient. We call that the psychiatric consult liaison service. But we need to improve in this area. This is where psychiatry has fallen down. We need all of you to advocate for this, to have the option for psychiatric hospitalization all across every state, every region. This is such a travesty that we don't have better support in this area. Just briefly about the promising, exciting scientific future of treating ASD, specifically about genetics. Autism spectrum disorder is a phenotype consisting in part of many genetic disorders. We're increasingly finding that when we do genetic testing now, we can find a specific genetic disorder, especially where intellectual disability is present, where seizures are present, where there is more than one sibling who has autism. It's more likely that we'll find this. In my experience, referring to our genetic service at UT Southwestern, it feels like the percent is much higher than 20% in terms of getting a response back where there was a specific syndrome. This syndrome can be informative in terms of understanding what a prognosis is like, what other people experience, coordinating with other families that are gathering their own experience over time, support groups, research, and so forth. One way to do it is through a clinical genetics service like we have at UT Southwestern. I'm sure other medical schools have the same thing. But also contacting Spark through the Simons Foundation, where you could get free testing done. And that's related to the research that they're doing. So if you're interested in pursuing that and you don't have access to an academic clinical genetics center, you could do that. Just some quick examples of my practice. A patient with MECP2 duplication syndrome might be entering a clinical trial to directly affect and improve their specific syndrome that gets to the the root of it, gets to the target. And this is some work being done at Baylor College of Medicine, where it happens I went to medical school. Just very quickly, another patient of mine with neurocutaneous melanocytosis, a lot of difficulty with sleep, agitation, and I was going through the literature. I did a search on this topic and insomnia, because we couldn't get her to sleep, and I came across a paper that showed dramatic improvement in a young child with this condition. So this is where your melanocytes have proliferated all throughout your body, including in your brain, and this article said that the patient had been treated with a melanoma drug and had dramatic improvement. I looked at the paper. I said, "Where did they do this?" And I looked at it. It said UT Southwestern. I was like, "Oh my goodness!" It's someone here at my own university. I reached out to them. We coordinated with the adult dermatology program. We went through all kinds of preparation and other kinds of things to make sure that this would be reasonable. We did specific genetic testing on her melanocytes. Make a long story short, we haven't proceeded with the treatment based on sort of the risk benefit of the medication specific to her particular medical situation. But this is a situation where we have this thing that, we're just using psychiatric medications, but we are almost to the point of using a completely different modality of medication. Last example here, a patient got genetic testing. I'm reading in the chart, the patient has EIF5A. I'd never heard of it before. I do a search on my computer as I'm reading about it. I find that there's experts in the UK that have a paper talking about a specific treatment that might be effective. I email them. I get an email back within 30 minutes, and they say, "Please provide us with more information. Would you like to get involved in our research with us?" And I thought, in what other part of psychiatry can you not have heard of the condition and 1 hour later being asked to help participate in the research? I thought that was pretty amazing. And it may lead to a new kind of treatment. Now, these are just the early examples. There are going to be more and more examples of this over time. I don't want to get people's hopes too far, but psychiatry is going to advance in this area. Neuroimmune disorders. Again, this is a really important one. I'd highly recommend reading this article here that I've linked on the side in the Washington Post. But many of you already know about PANDAS and autoimmune things that can impact OCD. There's a new new emerging syndrome called Down syndrome disintegrative disorder, where a person with Down syndrome has this regression. And the regression may be a kind of autoimmune encephalitis. And we have a couple of persons at UT Southwestern that have been diagnosed with this. And in fact, in one case, a parent coming to our ECT service saying, "My daughter has this condition," which they had never heard of, said, "I need your help." They were reluctant to go forward with the treatment that the mother wanted, which was ECT. But after this, by the way, this was not my patient, so I'm not intimately involved in this case. But this patient had dramatic improvement from her catatonia, from Down syndrome disintegrative disorder. However, the important takeaway here is that you do a neuroimmune workup. That workup may show a neuroimmune disorder, which may lead to treatments where you're targeting the immune system and you're not using psychiatric drugs, or the psychiatric drugs are just an addition. So that's pretty exciting that we've not diagnosed some things properly and we have a better treatment going into the future. How do we conceptualize? I'm almost done, by the way. We'll take questions and I'll stay however long you guys want. How do we conceptualize the role of the adult psychiatrist? Little graphic here that is the way that I think about it. You have an adult psychiatrist who coordinates with other areas, whether it's hospitalization, whether it's the interventional psychiatry, refers to things like transmagnetic stimulation, ECT, maybe ketamine or Spravato. You're working with your neurologist that does seizures, the geneticist that's providing you with more information about what specific condition might be in play. You're working with your medical doctors, research, academic centers, research, maybe coordinating with legal regarding guardianship, social workers, therapists, and so forth, diagnosis, ABA, and so forth. This is how I think about how a psychiatrist is useful in coordinating this big system. Just throw up this slide. You guys can maybe look at it later if you want more information, but these are from other centers where they provide information for families that you can have these electronic meetings. Of course, I don't need to tell most of you that we have great information coming directly from the National Council on Severe Autism, including the very great podcast that we have, which I've learned a ton from, and these things. So this is my last slide, and we'll take questions. Psychiatrists, we need them. We need them for adults especially. We don't have enough. They don't have the training and confidence, but they can gain it, and you can work with them to help them gain that experience and become experts. We don't need just experts. We need every psychiatrist for this to be part and parcel of what they do, just like depression, bipolar, and so forth. Treating autism needs to be part of what every psychiatrist can do. And I don't want to make there are lots of psychiatrists doing it, but many of them don't have the full confidence that they really need and will gain over time. We can help with severe behaviors, and I think there's a promising future with advanced treatments coming up. So I'll just leave the presentation at that. Sorry I went too long, and we can take questions.
Thanks so much, Dr. Westover. That was absolutely terrific. We got a lot of people just writing in saying this is so helpful. Thank you so much for this information. So thank you so much. We have so many questions. We won't be able to get to most of them, but I'm going to just spit some out quickly. First of all, people have been asking about slides and the recording. Yes, this is being recorded. We'll try to get it up on our website, ncsautism.org, tomorrow. People also asked about getting the slides. I'll ask you, Dr. Westover, for the slides. If those aren't available, at least you'll have the recording. And a couple of people have asked, can they become patients or can they do a telehealth with Dr. Westover? Maybe you want to address that straight away.
Really quickly. So first off, telehealth rules require that a patient be in Texas. And so, yeah, in short, I have a very full, mature practice. I am accepting new patients, but it's difficult for me to accept very many new patients. I do have a resident that's working with me that helps me accept more patients. I have a nurse practitioner that is signed on specifically for autism, and she can accept patients. We have other providers here at UT Southwestern that accept patients that in our transitional age youth program, Dr. Jessica Moore, and so forth. So there is some capacity, but it's certainly not going to meet the demand. We need more psychiatrists and beyond just UT Southwestern, in private practice everywhere. So UT Southwestern is also vacillated in how willing they are to accept outside referrals. So just keep that in mind. It's not a simple process, but we're happy to help where we can help.
Yeah, thank you. We just need to clone you a couple hundred times and we'll be good. People have asked about pharmacogenetics testing, like GeneSight.
Right.
Do you find it helpful?
I'm not a big fan of it. And the reason I'm not a big fan of it is because the science, in my opinion, backing it is not mature and not accurate. So we can't determine whether an antidepressant is going to work based on one allele or one gene. We know that from we can't determine that from antipsychotics or basically any medication. Now, where I think it can be useful is where we're determining whether a patient is a fast or slow metabolizer of medications. So there can be some utility. So I almost never order it in terms of suggesting it, but if a patient and family wants to do it, I'm happy to do it. So I consider it a fairly limited utility, at least at this point in time.
Great. Somebody asked about over medication. And for example, if your child is in a residential setting, have you had to deal with that? I mean, I know there's a history of just trying to kind of tranquilize, people. Do you have any thoughts?
Right. Yeah, that's complicated because we call that polypharmacy in psychiatry, where a patient ends up on many medications. So you can imagine if you're only doing one change at a time, you might say, well, I don't want to disturb this because we're doing this other thing, and you may just tend to accumulate medications over time. I kind of joke sometimes that psychiatrists, like you switch psychiatrists, and the first thing the new psychiatrist says, you've got too many medications, polypharmacy. We're going to fix this by reducing it. And they reduce everything, doesn't fix it. Gradually, more medications are added on. You're back to polypharmacy, and then it repeats itself. Someone new comes along and says, what's this regimen? Let's fix it. And so you kind of go through these expansion and reduction cycles, which are pretty common. Again, this just gets to the art of medicine, of doing this in a rational way where you can interpret it and try to keep things simple where you can by minimizing side effects. So I've had patients that came to me that said, the family says they've been on these medications for 10 years. Has anything ever been changed? No. And I'm like, it's a huge long list of medications. It's like somebody was just filling out the scripts every time. Someone has to come in and say, okay, let's gradually work on this and simplify things.
Medical cannabis. Do you have any opinions about that?
Most of what I think about this is not from the literature because I don't think we have great literature. I'm not an expert in cannabis literature. I have some patients, families that say it's been effective, and some patient families say that it's not been effective. So I'm kind of in this area of I'm being open to it possibly having a role, but it might be an overstated role. We don't know yet, in my opinion. But definitely, anecdotally, I get all kinds of reports.
You mentioned drugs like Ozempic to deal with the weight gain that's often a side effect of, for example, the antipsychotics. Can you say a little bit more about that? Have you had experience with
Right.
that with your patients?
Yeah, so Ozempic and those medications, the GLP-1 drugs, they're pretty amazing medications. Um, I've decided, and I've talked to a number of my colleagues, most of my colleagues feel the same way, that it is beyond the scope of a psychiatrist to prescribe those medications. However, I do refer patients to providers trying to get those medications. Now, I have other psychiatric things I can do, like switching antipsychotics to one that's not prone to weight gain or adding metformin. I do feel comfortable using that diabetes medication. There's a lot of studies that show metformin may have a role and so forth. Other psychiatric medications that may have a role in reducing that, but it can be complicated. Some of the folks that we work with don't have the best diet, aren't willing to eat healthy foods, and controlling appetite. Some people have insatiable appetite with the particular condition they have. It can be a real challenge. Luckily, we're getting better and better medication. So I don't personally prescribe the GLP-1s. I want to say most of my clinical experience with patients getting GLP-1s has not been in the autism world, but more in the general adult world. But it's a very common thing that psychiatrists deal with. So most psychiatrists should have experience and ideas of how to tackle this.
A lot of people are asking about other specific medications. I'll ask you about these, and obviously,
Right,
as you say, everything's very specific to the patient. So,
right,
um, I,
right,
but for example, somebody is concerned about Klonopin. It helps her daughter with aggression, but she's afraid
right,
to use it regularly as it may stop
right,
working and it may have long term.
right. So this goes to like that example of the patient I described where he had been on 5 milligrams of Klonopin, and which is a high dose. And another psychiatrist or provider come along and said that's way too much. So benzodiazepines can create tolerance and can have withdrawal side effects. So the tolerance is related to the idea that the medication becomes less potent over time. Withdrawal side effects relate to suddenly stopping and having withdrawal syndrome, which sometimes can be dangerous, especially if the dose is high. The medications can be dangerous when combined with other sedating medications like opioids. You should be very careful or not combine them with opioids. Definitely, alcohol should not be part of the picture with benzodiazepines. However, we know from the literature that patients, for example, Ativan, we know for people with catatonia, they can tolerate sometimes up to 20 plus milligrams a day, which is a super high dose. It's the kind of dose that your pharmacist would look at and say, I'm not going to fill that. Almost every patient that I have that's on that kind of medication, for example, Ativan, is on 8 milligrams or less. There are a couple of exceptions where I have patients on higher doses of medications. They're not sedated. And the reason they're on that high of a dose is that it has been effective. So you can do it safely, you can do it carefully. Clonazepam is a longer acting benzodiazepine. We could argue that lorazepam may be safer theoretically, but I think it can be safely done. And in some cases, it can be dramatically effective, especially where we are targeting a specific syndrome or condition that we know responds to that particular kind of drug. So I think in some ways, benzos get a bad name, but they definitely are a tool that should be part of the toolbox.
Okay, just maybe two more of the drugs. Naltrexone, what is your experience been? And then the other one she
Yeah,
mentioned was clozapine.
yeah, naltrexone. So naltrexone is a medication that's most often used, at least in the psychiatric world, for alcohol addiction. It may decrease a person's desire to drink. However, it's also used sometimes to help people reduce appetite and lose weight. You have to monitor the liver with it. I think the results in weight loss may be a little bit modest, but it's one of those things that may be a lot cheaper. It's generic in terms of using that instead of like a GLP-1 medication. So I think it's worthwhile to potentially try that medication. Usually side effects are not so bad. You monitor the liver. Clozapine, that's an antipsychotic that is very unique and that has to be closely monitored. The first 6 months that you're on it, you have to get your blood drawn once a week, and we have to monitor to see whether your immune system is still in good shape. There's a very small risk of your immune system going haywire with that medication. Um, the role of clozapine is specifically often related to treatment-resistant schizophrenia. So some people who have psychosis and schizophrenia, they respond really well to that drug and don't respond to any other drug. So the situations, for example, in autism that you might have people use that drug would be where other easier to use antipsychotics have not been effective. So every psychiatrist can point to examples where that drug worked where no other drug worked. So that's why we still use it. It does have a lot of side effects, though, besides just the immune system issue. Weight gain is another issue. Constipation can be terrible with that medication, drooling, and other kinds of anticholinergic side effects.
Got it. Okay, I'll do just one last specific drug. I was
Yeah.
on a question. Trileptal was a game changer for
Mhm.
this young woman, being used more as a mood stabilizer. Her violent outbursts were reduced. Your experience?
So that's a good example where a drug that doesn't get used a whole lot in psychiatry may have a tremendous benefit. So I'm betting that many other drugs were tried before trileptal, which is oxcarbazepine. And I think, if you're in a situation where that drug works, that's like hitting a home run because it's inexpensive, it's relatively low in side effects. And that just goes where you've worked with someone over time that said, okay, we tried this, let's try this. Sometimes you'll hit a home run. Sometimes the analogy I use is like, we're mining for gold. We've dug here, we've mined here. This looks like a promising place. Let's try again. We discover gold. And I'm like, I told you, if we kept looking, we'd find gold. And so um, that's a case of that. It doesn't get used, I think, a ton, but it has its utility.
There were several comments about, the importance of finding any underlying medical conditions that could be
Right.
leading to agitation and severe behaviors. And somebody mentioned esophagitis, for example. And I know people have also mentioned having trouble. You mentioned this like in your presentation,
Right.
but it's often difficult, for our kids to be examined. They often can't
Exactly.
talk. Like my son, he was self-injuring the other day. We had absolutely no idea
Right. Right.
what was
So,
leading.
like really quickly along these lines, uh, this patient's sister might be on the webinar right now, but we discovered in a particular patient that he had a genetic syndrome, a particular genetic syndrome. As part of this genetic syndrome, there's often an esophagus problem. We know that from the syndrome. So we learned the syndrome, and that was like, okay, he has problems swallowing. He might have this problem with his esophagus. They go see a specialist with some travail, finding someone who can do this. And this particular patient doesn't tolerate procedures pretty well, but we were able to discover and help a medical issue that was specifically related to a genetic syndrome that we discovered through our genetic service.
Very good. Question, what is the difference between excessive and purposeless motor activity and physical stimming? Like, most people with autism will stim, right? What's the difference?
I think that is a matter of judgment and looking at the bigger picture. So with this catatonia thing, I think there is a level, it's not like sometimes it's close to 100% confidence, sometimes it's close to 0% chance, but sometimes it's somewhere in between. And I've been in situations where we thought it was one thing, but I thought in the back of my mind it could be catatonia. So this is just an example, right? Is this just an autism symptom, or is this a catatonia symptom? And I'll give you like a quick example. This was not related to autism, but Down syndrome. Patient with OCD, anxiety. We've tried some for 20 years and very debilitated and slow. And come to me for OCD treatment. We tried some OCD treatments, not particularly effective. I said, I think this could be catatonia. Might not be, but I'm not definitive. The presentation is not perfect for that. Let's try low dose Ativan. And which I got a message a few days later from the family saying he sped up to his normal speed for the first time in 20 years. And so sometimes sometimes you discover the answer through the treatment. So where you are not 100% sure. Now, doing something like lorazepam is low risk and easy. But of course, you have to have a lot more confidence in terms of going for something like ECT, electroconvulsive therapy. So I think, you really review all the possible symptoms of catatonia and you work with a behavioral therapist. You gather your opinion over time as you assess the biggest picture possible.
Okay. Question about these behaviors, which I think she's talking about catatonia behaviors. Are they only exhibited in young adults and adults, or are they also exhibited in children with autism?
It can be essentially any age. So, for example, Dr. Wachtel at Kennedy Krieger at Johns Hopkins has worked with many youngsters with catatonia. Now, my experience with kids, working with kids, is essentially zero. So I can't comment from personal experience, but I know from the case reports and things that, yes, it can be kids.
Okay, we're going to cut this off in a few minutes, but I'll try to squeeze in a few more. Okay. Incontinence.
Yeah.
Any comments? I mean, I think this is a really pervasive issue. I don't know if medications sometimes exacerbate it, but incontinence, I think probably urinary and also, in terms of bowel movements, is a huge issue. Are there medications that help with it? Anything?
Yeah, I mean, that's a big complicated question. So, for example, what is the cause of the incontinence? Um, are there medications that are contributing to the problem? There might be medications that can help depending on the cause. I think having a behavioral therapist involved might be very successful also in understanding that condition. I will point out, again, not to harp too much on catatonia, that in one of the major autism scales, new onset urinary incontinence can be a symptom of catatonia. So, I don't have any particular magic solution or one size fits all solution for that. But I think that's where, again, the art of the psychiatrist working with the therapist, with the parents, and everyone else to try to understand the underlying diagnosis or the underlying condition and understanding what treatments might be brought to bear. I think that's how you approach a situation like that.
Okay, it's 6:15, or at least here in California, it's 6:15. I'm going to ask one question of my own just to close out. Have you had any experience working with N-acetylcysteine as a supplement?
Very little, but some, yeah. With some patients, for example, treatment-resistant anxiety. I don't feel like I can say much more than that because my memory is that I can't remember anyone in particular responding to it, but I haven't used it very much, and I don't think I've used it with my autistic patients at this point in time. So can't really comment more on that particular one.
Okay, no problem. Well, thank you so much, and thank you for staying late. Everybody got a lot more questions about, is the recording going to be up? Are the slides going to be up?
Sure, yeah, 'cause I
Dr.
know there's
Westover.
things that they want to look at and some sources and things. So
Yeah.
that'd be great. So we can
Yeah,
have
if you can
everyone look.
shoot me your PowerPoint deck,
Yeah,
that would
sure.
be great if you're willing. And then I'll also get the recording up. We'll probably get to that tomorrow. So I want to thank you so much, Dr. Westover. That was absolutely terrific. So packed with helpful information and incredible context. Certainly, we have a huge amount of work to do to not only improve the toolbox available for our children, but improve access to people who can utilize the toolbox.
So,
And your reflections on that were most welcome. And thank you, everybody. I am going to stop the recording now, and I appreciate all of you coming here.
thank you, everyone.